morning all. My topic is double trouble proliferative retinopathy in diabetic patients with chronic myeloid leukemia. I have no financial interest in this presentation. Little background knowledge: chronic myelogenous leukemia is a myeloproliferative neoplasm affecting both peripheral and blood and bone marrow. Natural history: usually it follows a triphasic course where a chronic phase followed by accelerated phase and invariably progression to a final fatal blastic phase with a variable period of time. And ophthalmic involvement: either one is primary direct infiltration that can mimic uveitis like vitritis, choroiditis, retinitis, occlusive vasculitis, optic nerve infiltration, and also infiltration of other cranial nerves and as well as orbit. And there is a secondary indirect effect which manifests due to hematological abnormality of the parameters including anemia, and that manifest in hemorrhages and Roth spot. Retinal manifestation can occur before systemic manifestation also, so the importance of ophthalmology is to diagnose this condition is very important. This is a normal CML case picture as I have shown, and showing the hemorrhages distributed well up to the periphery. Whenever they CML coexists with proliferative diabetic retinopathy, although the pathomechanisms may be little different, but there is considerable overlap between the two conditions. In CML, anemia, leukocytosis, hyperviscosity syndrome, leukoembolization, angiogenic factors released, these all lead to the clinical manifestations, and the diabetic PDR also we get some of these manifestations. And this interplay between these two clinical entities and unveiling this interplay is a clinical task, a challenging task for us clinicians. So, diagnosis of in a diabetic patient continuing treatment for proliferative diabetic retinopathy, sometimes we need to be carefully look the clinical signs so that we will not miss the CML, coexistent CML. I will show some picture of some cases where these are the diabetic patients and in the course of their treatment they are detected as a CML. So usually it is told that posterior pole, it is spreads far across the periphery one. We should carefully look forward the Roth spots and other signs of CML. And Priya Vivi et al, they have used a terminology that is a string of bead sign. I will also show in my pictures also. In fluorescent angiography, we can notice this sign, string of beads. Usually in diabetic we don't find. It is usually signs of hyperviscosity. In some CRAO and resolving CRBO, you can find these clinical pictures. So diagnosis is very important. This is a picture of CML patients. As we can see, CFAN neovascularization in periphery in the left picture, and in right picture there is already proliferative stage patient presented to us with NVD and all fibrovascular changes. So now I am going to present some of my cases and where we stuck or where we get trouble treating these patients. This is a 44-year male, only 2-year history of diabetes. He came for routine checkup, but with the fundus finding, some doubt aroused. As you can see this picture, we can notice some vasculitis signs, typically vasculitis like picture. Carefully noticing some Roth spot can be elicited. So we did an intensive workup. Besides diabetic, we also look for other causes of vasculitis as well as normal peripheral. CBC is a very low cost test that can be ordered in every diabetic patient. And we found that there is a high leukocyte count, white blood cell count, and on cytogenesis study, this is the angiography picture. As we can see, this is extensive ischemia in all quadrant. Luckily, the macula area is a little bit spared, but extensive CNP area along with neovascularization in other areas. So, cytogenetic study, it is confirmed that it is a CML case, and see, measure signs with all this, and this is the OCT picture with macular edema. So now where we went to trouble this macular edema was so intractable. This patient was very compliant. We kept on giving anti-VEGF regular interval, and macular edema was responding definitely, but again it was coming and coming and coming. So like 12, 13, 14 injections. Initially, also by the advice of hematologist, hydroxyurea used, which usually act as rapid cytoreduction. Hydroxyurea along with allopurinol to combat the side effects, and then when the blood counts little bit stabilized, imatinib started along with oral anti-hypoglycemic. In the meantime, we ocular treatment continued, and we did also pan-retinal photocoagulation. But despite this aggressive treatment and patient finally regular anti-VEGF, patient vitreous hemorrhage result. That is not the only problem. After surgery also repeat hemorrhage occurred. So again vitreous lavage was required in this patient. So this is another patient, this is the follow-up period. You can see we feel that okay, this condition is fine, but no, in long-term follow-up, ultimately they lead to some end up in surgery. This is also another case, same intractable macular edema, multiple injections we required, and dexamethasone implant also. So these are all cases despite good PRP laser and multiple injections. This is our case also, same. So what we problems encountered, I am talking, this is one problem that resistant macular edema. So obviously I will need the opinion of our expert present here, and frequent need of surgery despite aggressive treatment, and also we should consider the drug related factor, that is imatinib. Periorbital edema most common, but already some hemorrhage, retinal hemorrhage, vitreous hemorrhage also has been documented. So subretinal fluid, cystoid macular edema. So whenever possible, we will consult our oncologist to change the medications. The newer like dasatinib, nilotinib, and dasatinib also not documented, much literature not available, but optic neuropathy one case I found. And so these newer drugs we can switch if we feel that macular edema is not resistant. And so very aggressive approach is required in this patient, and we should be careful to timely pick this diagnosis, because we are thinking of we are treating diabetic retinopathy and we are getting another disease. So some points need to be discussed, or some that screening guidelines, should we alter the screening guidelines? How aggressive and which treatment? Like in optic neuropathy, we have already methotrexate and rituximab we are using. I have not used this drug for this retina conditions, but should we switch to those drugs? And third is early switch to other anti-VEGF or steroid. If anybody has any experience in using this drug, because dexamethasone implant, I have also switched to dexa implant. And what precautions should we take during surgery? This is also a doubt. Why all these patients develop recurrent bleeding, and again vitreous lavage was required for these patients. So thank you all of you for the kind listening. Thank you.
Any comments from the audience?
I have experience with one patient who I was treating for non-proliferative diabetic retinopathy for several years with DME. So he was quite mild disease, but he started imatinib for his CML or AML, and suddenly he progressed to neovascular glaucoma in one eye. He just came with pressures of 60 plus, severely painful eye, and the other eye also started developing vitreous hemorrhage. So when I read up, not only for this case but for other cases as well, we have seen that these newer tyrosine kinase inhibitors, TKIs, they have so many ocular adverse effects that they can have any adverse effect from the cornea to the retina, and in the retina anything, vitreous hemorrhages especially, recurrent vitreous hemorrhages without any neovascularization, recurrent CME or almost anything. So this patient, we finally managed to treat the neovascular glaucoma and the hemorrhages, but what I'm saying is that our vigilance should go up once they are on these TKIs. And any patient who comes with unexplained vitreous hemorrhages, we should look into their history of medication, and if they are on TKIs, we should request change of the TKI.
I also had an experience of patient with a CML NPDR with a branch vein occlusion presented with vitreous hemorrhage in one eye, NPDR in the other eye. And in case, one eye got vitrectomized, was treated with hydroxyurea. This is of almost about 15 years back. And the patient responded pretty well. So it's important to treat the baseline disease, and after that we made it a point in every patient in diabetics, if we find any vasculitis, we make sure we investigate it completely. Every patient we get a hemogram done, and we look at the leukocyte count, because that is very important. For
That
this.
should be
Yes.
routinely included.
Thank you, Dr. Arora.
Thank you, sir.
Thank you.